Hello everyone, welcome back to my YouTube channel. This is Dr. Aishwarya Gupta. For today, the topic is ECG. Very specifically restricted to the exam entrance exam. I will not be covering anything basic, which is irrelevant at this point of time. I'll be showing you ECG images, and along with that, I'll tell you the keywords and which are there in the question stem and help you to come to the diagnosis even when you not know the ECG properly. So yeah, first thing is tachycardia can be divided into. Yeah, a narrow QRS complex and wide QRS complex. Narrow QRS complex, the QRS time is less than 120 millisecond. That is more than 120. Narrow QRS originates from the AV above the AV node or within the AV node. So it is the pathology is mostly in the atria. So the reflected ECG changes will be in the P wave because the atrial contraction is represented by P wave. While in a wide QoS complex, the changes will be in T wave because the originate below AV node. Origination is below AV node. And these are the topics which I'll cover in wide QRS and narrow QRS. And I think you should focus on this because it's very important to place the disease correctly. That will help you to differentiate better if you know where it is which is one is wide QRS, which one is narrow QRS. Now coming to the thing, atrial fibrillation. Atrial fibrillation is irregularly irregular. And there's no discrete P wave. All right, so you can see in the ECG also there's no P wave pattern which can be actually appreciated. It is associated with hypertension or CAD and even can cause thromboembolic events. So you have to look in the question the respective history. They'll give you clinical features, may not mention it directly. You have to do cardioversion if the patient is unstable. Otherwise, you can do rate and rhythm control. Now, atrial flutter is very classical sawtooth P wave which are very identical. It is due to re-entry circuit. Re-entry circuit, I feel that you must be knowing, so I'll not explain. And treatment is in line with atrial fibrillation. You can even, in fact, do RFA because if there's a re-entry circuit present, you can do radio frequency ablation. Now, PSVT has been asked many times. You have to look for the keyword sudden because it's sudden onset, and the clinical features are very similar to panic attack like palpitation, lightheadedness, diaphoresis. They may give you one of the options as panic attack, but I don't think if the answer if they are expecting answer is PSVT, they'll give you ECG along with that. Treatment is IV adenosine 6 mg bolus, and the sacks very fast, like in 1 or 2 seconds. You have to do electrical cardioversion if the patient is unstable, and vagal maneuvers are also appreciated, like carotid massage. Now, multifocal arterial tachycardia, this is also irregularly irregular. And there are three distinct P waves, which is due to re-entry circuit. That is why the treatment can be catheter ablation of the tract. So you can see different P wave morphology. In the first one, the P wave is small. In the second one, it is actually tall, and in the third one, you can see actually split P wave. And you can it can be present in COPD, pneumonia, or heart failure. And you have to look for maybe the patient. They've mentioned in the question the patient may have history of smoking, something like that. Now, Wolff Parkinson White syndrome. It is due to bypass pathway of Kent, which is a fast pathway, and there is no along with the regular pathway, which is a slow one. So what happens is the current reaches through the fast pathway, and there is a contraction of the ventricle. So QRS complex becomes enlarged because along after the fast pathway, the current through the AV pathway is also reaches the ventricle. So that is why there is a wide QRS, sustained contraction. There's no AV delay. The filling is also reduced. So there's you may read it in detail if you want to, but this is enough. They will not ask pathology very much. Treatment is RFA because you have to ablate the Kent pathway so that the patient may survive better. And the treatment is also prosenamide, which is a class 1A drug and antiarrhythmic drug. And along with that, read all class 1, 2, 3, 4 antiarrhythmic drugs that have been asked. A very classical delta wave is seen, which is a clincher in ECG. You can see that it is due to pathway of Kent. Now, ventricular tachycardia. This is due to some structural heart disorder, maybe due to MI or cardiomyopathy. And there's regular rhythm, but the rate is more. So you have for rate control, you have to give beta blockers or calcium channel blockers. Calcium channel blockers, you have to give non-DHP, which are verapamil or diltiazem, not the ones which act on vascular system. It can also cause certain cardiac death if it's not managed properly. Now coming to ventricular fibrillation, there's no identifiable wave pattern here. No identifier. We can see clustering. Nothing is there. And if it is fatal if it's not immediately followed by a CPR. So already these pointers have been asked like many times, and especially the drugs which are related to it, which I have mentioned in the end, along with the mnemonic. It can also be caused by deficiency of magnesium, or not deficiency, but when it's reduced, yeah, hypomagnesemia, hypocalcemia, and hypokalemia. If the patient is stable, you can give MgSO4 because it's most likely an iron disorder, and otherwise, you have to defibrillate. Now, conduction blocks are asked regularly. I remember, in fact, it was asked in INI set also, and for that matter, I guess in NEET also. So, conduction block you'll understand with an example of a long distance relationship. In first degree conduction block, the PR interval is more, but it stays equal. There is no drop beat. So, every PA is followed by a QRS complex. This is a happy long distance relationship where both people are actually, interested to keep the relationship going. So, no issues. In second degree, this is Morbus type 1. There's the progressive lengthening of PR interval, and suddenly there is a drop beat. So in this relationship, so both people are not finding it easy to stay together. So eventually they drop out voluntarily. So this also doesn't require any treatment. In Morbus type 2, this is the most dreadful because there's the PR interval, there's a PR interval stays equal, and then there's sudden drop beat. There's some structural issue. You can understand that in this one, the relationship is working fine, but eventually someone will find some other person, and the person who is left behind will have to suffer. So there you have to give treatment as well because the PR, everything is working fine. Both parties are putting in equal effort, but suddenly some person will choke somewhere else. Yeah, that came out wrong. Third degree heart block. So this is the best kind because ये वो वाला है जहाँ पे चार लोग खुश रहते हैं. The the P wave and QRS complex are not related at all. This is rhythmically dissociated, and treatment is pacemaker. This complete the tachycardia, and for the sake of even more, if you want to put a full stop, read about bundle branch block and premature beats. Not much is there. You can see it. Now, sixth sinus syndrome is the age-related disorder of sinoatrial node. There is a bradycardia on ECG, and you will see a bradycardia. It may be also very easy question, long PR interval. Now coming to hydroxylopathy, Brugada syndrome is asked. This is autosomal dominant. There's loss of function mutation of sodium channel. All right. And ECG, you can simultaneously look at the picture also. The point A represents broad P wave. Point B represents J point elevation. And there's a curved ST segment that is convex upwards and inverted T wave. J point elevation, Osborne wave, you also see in hypothermia. Now coming to congenital long QT syndrome, there's Roman ward and Langer-Nielsen. Roman ward is autosomal dominant. This is autosomal recessive. There's only cardiac defect and there's cardiac plus sensorineural hearing loss. So you can understand, remember like that the ward boys working in the ward should not have any hearing issues. So the first one doesn't have SNHL. And one more thing, the story which I told you about the conduction block has not been incepted by me. Actually, it was told by Zainab ma'am. So credit goes to her. Now coming to the drugs in induced long QT, which can be remembered by the mnemonic ABCDEF plus NO. For A, it is antiarrhythmic class 1A and 3, and arsenic for that matter, and antibiotics, fluoroquinolones, and macrolide. Antipsychotics, remember it is C, and the tricyclic antipsychotic, diuretic thiazide, antiemetic ondansetron, antifungal fluconazole, and now that is your protease inhibitor, and opioid methadone. So that's it from me today. I hope you understood. And for ECG, I think this much is enough. This because image remain the same. Questions 10 may differ, but if you see this properly, you're good to go. And one thing I think which I have missed is one question where the expected answer is cardioversion. They'll give you a scenario of a patient which is who is collapsing, may have hypotension or something like that. So that you may do from PYQ and revise it 2 3 times. See the images. I think you're well sorted. And all the best. See you until my next video. Thank you.